Great.
Testing one, two. Testing one, two. Okay. So I gotta click the audio and something. No, right there. No, got to mute it somewhere else. Okay. That's no more feedback, right? Okay, sound is off there. Good morning, Chandra. Can you hear me okay?
Hello.
Hi, Chandra. How you doing?
Hi, John. Good evening. Happy to join this session. I am actually speaking from my phone right now, but I'll join from my laptop in, say, about 10 minutes.
Yeah. We got plenty of time. We got 35 minutes.
Yeah. Okay, great. Then in maybe 15 minutes, then I'll join.
Okay, I'm here.
Okay. And who's going to be speaking first?
I believe you are. I believe so. We're not too rigid, you know. We kind of
No, fair
go-
enough. I am
go-
happy to talk first. I just wanted to be sure. Huh.
Yeah, I'm not sure. I kind of leave it to them. I
Okay.
introduce Ben, and he'll give you the proper neurosurgery introduction,
Okay.
and then he'll decide if he goes for the other speaker or you. But usually it's the feature speaker, which is you.
That works for me.
Okay,
No issues at all.
great.
So I'll leave you for say 10-15 minutes and I'll join back soon.
Okay,
Thanks.
we'll be here.
Yeah. Thanks.
Hi, Jesse, are you here? Greetings, everybody. Let me get this screen off. All right. Dr. Jane, good morning. And Dr. Luckman. And there's Chandra. Hey, Chandra, can you hear me?
Yeah,
Okay. Is that Mumbai, the bridge?
I must increase my volume a little bit.
Okay. No, it's okay. It's okay for me. It's
Yeah,
fine.
it's good now.
Yeah, my some good friends are going to India in a day or two. But of
I am
course,
not seeing.
yeah, I don't see your camera. There you are. There you are. There you go. Is that Mumbai in the
So
background?
there is some switch in my new laptop. I have to press one switch before my picture can be seen.
It's fine. Is that Mumbai, the background?
Yeah.
It is Mumbai?
Good. So I just wanted to be sure. I haven't checked many of these webinars. Is there some kind of a translation or how does it work?
Yes, there is, but you won't even know it.
Okay.
There's someone on the panel now that I don't even know she's here. She comes in as a panelist, mutes her microphone, and has another separate Zoom, which she is spontaneously translating to another Zoom or another video platform of one of the best. I think it's the best neurosurgery video website. It's Chinese. It's mention.com. And let me bring you there. We got a minute or two.
Okay.
I think it's the best video.
Can you hear me?
Yes. Can you hear me? Am I muted? Hold on. Okay. Let me see. Can you hear me now?
Yeah.
Okay. Let me just show you the site.
No, it's much better now.
Yeah, it's medtion.com. This is a translation because there's an option to get a translation. But you know, these websites, they give you the Chinese, but you don't know what the button is to translate.
Okay.
But you'll figure it out.
Somebody is doing simultaneous translation.
Yeah, you're right. Let me show you right now. You're on.
Right.
We're on now. See it here? See China Neurosurgical. There we are. Yeah.
So you can see that's the bridge near my home, connecting old Mumbai to new Mumbai.
Oh, okay. Okay, I'm gonna stop. I didn't realize that. Yeah, of course, Mumbai's on the ocean, of course. Let me check. I gotta check. Let's see here.
I was specifically interested in time because I was traveling today.
Oh, okay. Okay, let me, I got a message here. I'm not used to communicating in WeChat. Oh, Ben can't make it tonight. He has another meeting. Okay. Then Wanli, are you there, Wanli?
Hi, yes, yeah.
Good, how you doing?
Good, yeah, it's okay. Huh?
I'd like to introduce you to Chandra Deopujari.
Hello.
Yeah, I think, yeah. Hi, Dr. Deopujari. Yeah, nice to meet you.
Nice to see you, Dr. Zhao.
Yeah. So
Yeah,
you're in Mumbai, right?
Yes, I'm in Mumbai.
Oh, wonderful. Yeah.
and,
Yeah, we have another speaker, Dr. Zhang, also here from same hospital.
welcome.
Okay.
Welcome,
Dear
Dr. Bennett.
professors, I'm Wei from Kenai Hospital, Chief Neurosurgeon. Yeah,
Nice to meet you.
Okay.
nice to meet you.
Yeah, I'll introduce you, Wanli, okay? And you introduce Dr. Deopujari.
Okay.
Okay, Wanli.
I think,
Let me just briefly tell you about Dr. Pujari. First of all, he's a great guy. He's done a lot of these webinars since the very beginning. But professionally, he's the head of many associations. Perhaps you can tell us, Chandra. Just a couple of big ones, but I'm sure the big Indian ones.
No. I'm now probably getting out of most of the association. I'm mostly in the advisory council now. But yes, I with a few colleagues founded the Neuroendoscopy Society in India. I've been the president of the National Society and the International Society for Pediatric Neurosurgery, and headed the WFNS Committee for Neuroendoscopy.
You got that one, Lee?
yeah. I think, yeah, I know Dr.
We did a neuroendoscopy course at your hospital, I think 3 years ago in 2019.
That's
Is
great.
that not correct?
Is that correct, Wanli? Do you know?
At the time of the World Congress interim meeting?
Oh, yeah. That's 3 years ago, huh?
3 years ago. Dr. Chen was with us.
Yeah, wonderful.
Very good. Okay, gentlemen, you ready to start? Hold on. Give me a minute here.
Yeah, today Bing has another meeting, ACNS meeting. So he told me he cannot be here. So
Okay.
never mind. Yeah. So we will have Dr. Deopujari as the first speaker, right? And then Dr.
Yeah.
Zhang.
Okay. That's how we normally do it.
Okay.
Here, just give me 1 second and we'll be starting. And welcome everybody.
So is Dr. Zhao moderating the session today?
Yeah.
Okay,
Yeah.
great.
Okay. Okay, here we go. Let me tell Prakash, she's coming in. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It gives me great pleasure to introduce another in the webinars of the Cerebral Vascular Journal, the China Neurosurgical Journal Webcast. And today we are graced with Chandra Deopujari, and I'll let Wan Li Zhao, neurosurgeon and director of cerebral vascular surgery at Beijing Tiantan Hospital in Beijing. Welcome, Wan Li, it's all yours.
Okay, thank you, John. Hello, everyone. This is Yuan Li from Beijing Tiantan Hospital, China. And this is our bi-weekly webinar of Chinese Neurosurgical Journal. And today we have two speakers. One is Dr. Deopujari from India, and the second speaker is Dr. Zhang from our Beijing Tiantan Hospital. And now let's start. So the first speaker, Dr. Deopujari, is from Mumbai, India. He's a world famous neurosurgeon focused on many subspecialty like pediatric neurosurgery, cerebral vascular surgery, gamma knife, and skull-based endoscopy, anything. Yeah. So tonight, actually now it's 8 p.m. in local time in Beijing, and I guess it's around 5:30 in Mumbai, right?
Yeah.
Okay, and tonight, Dr. Deopujari will talk about cavernous angiomas in eloquent areas. So, please.
Thank you very much, Dr. Anil. And I'll share my screen. Am I visible?
Yes. You want to make it full size?
And reasonably audible?
Yes, I can hear audio, but
Okay.
Okay, there, perfect.
So what I'll do over the next few minutes is to talk about the cavernous angiomas in eloquent areas. I think all of us know that cavernous angiomas over the last 25 years have become one of the topics of interest in vascular neurosurgery. And this is mainly because they tend to bleed. There is recurrent bleed, probably as frequent as AVMs. And there is a clustering, which is a peculiar phenomena that occurs in some patients. And occasionally they can present with progressive neurological deficit, or sometimes even asymptomatic increase in the size of the lesion because of silent hemorrhages. And what matters during surgery is probably the accessibility, especially important in the eloquent area. And image guidance and IONM have made a lot of difference to how we treat these lesions over the last 2 decades. Lesion size has remained a controversial indication, and IONM has certainly helped, as we'll see when we go further. And it's not a surprise that like many other things, Walter Dandy has the first honor to operate on a brainstem cavernous angioma way back almost 100 years ago at Johns Hopkins successfully. And if you look specifically at the eloquent areas cavernous angioma, especially the deep ones, Gary Steinberg has written this article about brainstem, thalamus, and basal ganglia together, about 176 patients. And he shows in his experience that symptomatic deep cerebrovascular malformations, especially the cavernous angiomas, can be resected with acceptable morbidity and outcomes, and good preoperative modified Rankin score and single hemorrhage are predictors of good long-term outcome. So earlier we were always talking about repeated bleeds to be an indication, but I think single hemorrhage, especially given the location, probably is a good indication. When we talk about radiosurgery, I know there are several reports coming up that probably it is useful in some areas, but the fact is that right from the first paper, it seems that it does not give protection against hemorrhage in the first 2 years after the treatment. And after 2 years, it does help, but there is a significant risk of radiation damage. So currently, probably inaccessible lesions can be treated with 12 to 14 gray marginal dosages, seems to be the message which comes from this. And I will not discuss radiosurgery much further when we are talking about this disease. We wrote about deep-seated cavernous malformations in a journal about 7 years ago. And I think the most influential paper in the last decade has been the Lancet paper, which talks about the fact that primary outcome of cavernous angiomas depends mainly on two things: the clinical presentation with hemorrhage, and if there is a history of previous hemorrhage, it certainly makes you more prone to have further hemorrhages. And second is the location of the hematoma, especially brainstem, which seems to be 4 times more prone to hemorrhage than any other location. And both these are independently associated with increased morbidity and mortality. And if you look at these two charts, you will realize that if these two things are taken together, the morbidity and mortality, if left alone, for brainstem cavernous angioma is almost 4 times more than an asymptomatic non-cavernous hemangioma. Furthermore, this Japanese analysis of almost 200 patients tells you that probably in Asia, especially in Far East Asia, brainstem rehemorrhage rate is almost as great as 42%. I'm not sure what is the Chinese and the Indian data, because I did not see any published data on this, but apparently the risk of brainstem hemorrhage is much higher in Asian population if we go by the example of the Japanese study. DeRocco and his colleagues have also shown us that it is not only true for adults, but it is also true for children, that the brainstem and more than one hemorrhage are definite indications, apart from the fact that the Zabramsky type 1 and 2 have probably significant higher hemorrhage rate. So let us have a look at some of these cases. This is a patient who has had second hemorrhage, presented with 6th nerve paresis. As this was a second hemorrhage and patient was symptomatic, we decided to operate. We typically operate about 3 weeks after the event. And this allows you to take out the hematoma more completely without damaging the surrounding tissue. Otherwise, the surrounding tissue is very edematous and friable if you operate immediately after surgery. And this case was operated through the floor of the 4th ventricle. And you can see that after evacuation of the hemorrhage, the 6th nerve paresis has improved quite remarkably without addition of further deficit. And this is the scan done at 3 months, which showed a good excision. Frameless stereotaxy has come to our help when you are trying to make decisions about how to go further. DTI has helped us to tell you what is probably the best corridor to approach the brainstem. If there is no superficial evidence of hemorrhage, ultrasound can also help you to show where exactly it lies and where do you have to enter with minimal damage to the brainstem. And intraoperative neuromonitoring, most importantly, I think trying to see where the 7th nerve nucleus is situated, have saved many patients from having post-operative facial palsy. This is another patient who had a medullary kind of hemorrhage. She presented with weakness of the tongue actually. And this patient also had a midline surgery, and you can see on post-operative scan at 3 months that it has been completely excised with good recovery in this patient. Very rarely you get a patient who bleeds the first time and then progressively deteriorates. And this is one of the rare cases where we had to act very quickly in this young girl and after the first hemorrhage itself. And we had to remove this clot, as you will see, that there was no other option but to go from the fourth ventricular approach. And we are trying to go telovelar onto the side where she had a pre-existing 6th, 7th nerve paresis, but we tried to map it. When you lift up the tonsil, you can start seeing now that there is a staining in this area. The next step would be to map where the 7th nerve nucleus is. And the probe is being used to monitor that. Once we have seen, then we go lateral to that. You can see now that there is a little discoloration here, which is being further expanded, and we are entering the clot. Once the liquid clot starts coming because of the recent hemorrhage, and you will find that this cavity keeps on closing all the time because of the surrounding edema, and it becomes very difficult sometimes to, keep this corridor open. And this is one major reason why acute hemorrhage surgery probably is not such a great idea, especially in an eloquent area. Most of these patients stop bleeding after the first 24 hours, and then you get enough time for them to recover when you are operating. You get a better plane of cleavage while operating. This continues further. The cavity starts getting a little bigger. You can start seeing the edges of the clot now. You can start seeing the little white matter transparent to this area. And eventually, once you see the white matter all around you, you make sure there is no clot remaining. You irrigate continuously to make sure all clots are drained out. And then you close this. We try not to keep any Surgicel and do a scan the next day. You can see the scan next day does not look very good because there is plenty of hemosiderin and some liquid mixed hemosiderin. But at the end of 3 months, the scan looked all right. If you have a hemorrhage lower down in more anterior area, this is almost at the level of the lower cranial nerves. You have to be going almost far lateral. You don't need to drill the condyle, but you need to go as lateral as possible. And then we are going at the level of the lower cranial nerves, and we are going anterior to the lower cranial nerves. And then as soon as you see the staining, you are making an opening into the pia and start taking this cavernous angioma out from this area. And this is the post-operative scan, which shows that there was a draining vein which we left behind. This is another patient with almost 4 episodes of previous hemorrhage, and another center had tried to operate on this patient but could not remove it completely. And then he had the 5th hemorrhage when he came to us with 6th, 7th, and lower cranial nerve paresis and in a wheelchair. And this 14-year-old boy was operated at that time. Because of repeated hemorrhages, you will find that it's a very, very thick kind of a gliotic area around it. And fortunately, this gliotic area allows us to dissect this quite well and take this out, multilobulated thing, quite well. And this is the surface left behind. And you can see on MRI that you have got a very good resection done. And this patient actually woke up quite well. His Ryle's tube could come out in about 3 weeks' time. His tracheostomy came out in about a week's time. He started eating and drinking at about 3 to 4 weeks' time. And currently, 7 years later, he is now just started working as a chef at one of the local 5-star hotels. This is another girl, young girl, who presented with only 6th nerve paresis. And you can see that the hemorrhage is not so well seen, and acute hemorrhage may not be so well seen except for this area of hemosiderin staining. and on FLAIR images, you can see it much better, and it is situated just under the fifth nerve origin. And when you do a tractography, you can see that the only corridor here is just underneath the fifth nerve. So in this kind of a patient, with the help of navigation and with the help of IONM, you try to go as lateral as possible. And once you have gone there, you have, this is the seventh. You will be able to see the fifth very quickly. And once we have made sure that we are at the proper level, you get a good corridor laterally between the fifth and seventh. And you start removing the lesion just under the nerve. The clot is coming out and bleeding of various ages slowly starts coming out. You can see it is getting dissected out reasonably well. One big nodule coming out first. And you can see there are two more residual nodules here. Obviously, you don't want to enlarge the opening too much, so you are cutting it out and making it into pieces while removing it. Though in other places we try to take it out as one piece, you cannot take that liberty when you are operating on a brainstem, especially through such a narrow corridor. And this is probably the last nodule which is now coming out. And you can start seeing the gliotic area surrounding it. That's the medial most. And you can see the nice plane just beyond that. You can see on the post-operative MRI that the lesion has been taken out well, and this girl actually completely improved in her sixth nerve paresis at about 3 months' time, and had just appeared for her first college exam. If a lesion is further anterior, then of course you need to use posterior petrosal, or what we used to call pre-sigmoid approach earlier. And in this patient, we have used the pre-sigmoid approach and directly gone in front of the brainstem, anterolaterally in front of the fifth nerve. And once you see the staining, we are opening this up with a diamond knife. You start removing the cavernous angioma. There are 3 lobules here. Once the blood comes out, then it can be taken out much more easily. As you can see that the mulberry kind of stuff has come out. You need to use angled instruments, of course, and many a times when such narrow corridor increase, you need to use shaft instruments, and endoscopy instruments can be liberally used in microsurgery in such cases. This is the post-operative scan, and again, this guy improved quite well in his cranial nerve function. In a higher, in the midbrain region, the approach becomes very difficult for 2 important reasons. That the only place you could have come from in this patient is probably through the Sylvian fissure, but this person had absolutely no motor deficit. He only had some eye movement disorder, and we thought we'll just wait for 2 weeks and then probably come for removal of this clot. But in the waiting period, he developed another hemorrhage. You can see a higher clot here, almost in the thalamopeduncular area, and the ventricular size has gone up. So I actually did interhemispheric approach and went endoscopic assisted approach to actually this area, went from the contralateral side so that it is easier to get into the thalamopeduncular area through the foramen of Monroe. And as you will find that the clot was almost presenting on the surface on the ventricular side, and through the choroidal fissure, we could actually not only make an opening, you could take this out quite well, as you will see in the next minute or so. The lower nodule is coming out now. And you gently need to separate it from the surroundings with the help of suction. Using a graduated suction is extremely important if you are operating in the midbrain or thalamic area. And at this location, I have found this approach to be quite useful, as I'll show you in another case shortly. So it could be delivered out completely. Then we check the cavity with endoscope to make sure that there is no residual, there are no clots, and irrigate enough to make sure that the cavity is completely clear. This is a young boy who presented actually casualty in a deeply drowsy state, and he had this hemorrhage. We did an angiogram to make sure that there was no AVM, and then we removed the clot which contained 3 lobules of large cavernous angioma. This boy took almost 3 months to get out of the hospital, but could walk, and in 6 months' time could join the school once again. This is actually a teacher who developed this and could not speak properly in the class. And when he came here, again, this is a difficult location to get it out. And by the time he came to me, his speech had become normal. So we decided to wait. And in about 3 months' time, he had another hemorrhage when the ventricles dilated. So I again went the contralateral transforaminal approach and managed to remove it through that approach quite effectively. As you will see here, you can see the staining there. And once you see the staining, you make a small incision, and then you can get it out almost completely. And make sure that you have been able to clear it out completely and confirm it on a post-operative scan. This is another one in the caudate nucleus. A young lady who was an executive found it difficult to work with her right hand when this happened. And then we removed this by a middle frontal gyrus approach, and she's been completely relieved of her motor disability. This is a young girl who presented with a seizure with speech arrest, and we were not sure if we should remove this after the first hemorrhage itself. But after understanding the whole natural history, the parents were very keen, especially the fact that longer you wait to remove this lesion, the epilepsy is less likely to get cured well, was one of the things which weighed on their mind. And we did fMRI with speech, and we did a DTI which showed that speech cortex was just adjacent, but not too bad. The main problem in these cases is that should you be removing the hemosiderin ring around it? And there are mixed reports. Some series have talked about removing the hemosiderin ring to get a good cure from epilepsy. Some other ones feel that it is not so important. What is important probably is the duration of epilepsy. And therefore, in eloquent area, especially in brainstem, you do not bother too much about removing the surrounding gliotic or hemosiderin ring. In this case, as you will find that it could be peeled off very easily through this sulcus. We enlarged this, and once we removed this, you can see that the hemosiderin, gliosis hemosiderin, actually peeled off very easily. And therefore, we took that out as well. And the girl woke up without any speech difficulty. And therefore, and actually has gone on to become, she is a junior, she's playing junior national championship in one of the sports in India today. This is the post-operative scan 1 year later. This is another patient, familial cavernoma, who presented with several seizures. They waited almost 6 years before she could be operated. So we did this awake, and we did a ECOG guided resection, and she could get a complete lesionectomy and has not had any seizure in last 8 years. Sometimes this patient, or this actually 11 months old child, who was referred to me as a tumor, and here we thought these multiple spaces probably represented bleeding, and it may not be a malignant lesion. And we operated this to the middle temporal gyrus, and you can see it was a typical cavernous angioma. So giant cavernous angioma is well described in children, and it can be difficult to approach, but it is not so difficult to remove. I think my computer has hanged for some reason.
Okay.
John, should I
Is
go
it-
back or
Yeah, if it stops, you may have to start again.
I stop share for a moment?
Yeah, just stop for a second and go back on.
I will try to share once again.
Okay.
Yeah.
You probably want to pass by.
Sorry
that
about
video.
that.
That's okay. You can just pass by that video. Or did you want to show that now?
I think I need not show that video, but I need to get back to the slideshow.
Okay.
So I will probably get at the beginning.
Yeah, just start again.
Okay.
It looks like you're trying to open an audio file. Is that true or?
Can you see the screen now?
Yes. Are you opening the correct file? You want to open
Yeah.
a PowerPoint, right?
So that is
Okay.
the post-operative MRI, where we could get most of it out except for what was stuck to the internal capsule at the end. This is another pediatric giant cavernoma, which was almost attached to the optic nerve sheath, but presented up in the ventricle, and there was a large cystic component.
Excuse me, Chandra, we're not seeing anything. We're not seeing it.
You cannot see?
No, we cannot see it.
Oh,
Okay. Take your time, no problem.
now?
Yes, we can see it now. Okay.
Okay. So this was a case of another giant cystic tumor in a child, which had a large cyst along with it, and this was stuck to the optic nerve, but we got it through the ventricle as the bulk of it had grown into the ventricle. It's not going further. Is it seen now?
Yes. And
Then I will run in this format only.
Okay, it's not complete screen, but that's fine. We can understand it.
Okay. No. No, it's not going any further. I'm terribly sorry. I need
That's
to
okay.
close and come back.
Okay.
I just need a minute.
Okay. Okay, I think Harshad had a question. in the
Yeah, you
meantime.
can have some questions in the meanwhile.
Yeah, go ahead, Harshad.
Yeah.
You're on the panel, right, Harshad? I
Uh,
believe you had a question.
I saw there's a question about what time should you do surgery, especially for those bleeding cases.
So I think if the patient is not progressively deteriorating, I usually like to wait at least 2 weeks. That gives enough time for the surrounding edema to subside. You can approach the lesion easily and you damage the surrounding brain much less than what you would do if you operate in an acute situation. Is
Okay.
this screen seen now?
Yeah.
Yes.
Okay.
Okay, so this is that cystic
Okay.
tumor. Through a small middle frontal gyrus approach, we got the cyst, drained the cyst. You can see the lobules of the cavernous angioma coming out, and you will find at the end of it that it was stuck to the sheath of the optic nerve. This is post-operative. You can see that recurrent bleeding can cause cysts in many of these patients, and cystic cavernous malformation is increasingly being recognized as a separate entity, and we actually published our experience last year on some of these cases. Some other giant cavernous angiomas which can cause diagnostic difficulties. This is actually one doctor's wife who presented with some visual disturbance and had this large lesion. And you can see that there is thinning of the fibers just around the lateral border of this. And we decided to go from a parieto-occipital approach in this, not to go into the visual cortex, not to go into the sensory cortex. We found a way here, and you could remove most of the lesion over here, as you'll find on the post-operative scan. And she improved quite well after this. This is another patient who's a school teacher and who used to develop tingling in her leg. And here it becomes difficult because it is lying, actually it is coming up to the surface, but in the midline. So in this patient, we had such a narrow corridor just behind the central vein, and it was really difficult to get into the space. And once you got into the space, to get a good retraction, to find the lesion and then to excise it completely was quite a task, and tested your patience, but it could all be taken out, as you can see in this specimen here. And this is the post-operative CT and the post-operative MRI done recently, and she's now completely, she stopped getting those sensations, and there is no foot weakness in her. So I think what you have to do in these eloquent area cavernomas, that you have to find the shortest way to the lesion without crossing the eloquent area. And if it is in proximity to the ventricle, find the nearest ependymal surface or pial surface. You have to use IONM if you are working in brainstem or basal ganglia, and you have to make an attempt to remove it completely. As 3 of our patients, we had to go back in for the residual lesion. And if there is a venous angioma associated with it, try to preserve it as much as possible. And preoperative DTI for working up the operative strategy, intraoperative ultrasonography, neuromonitoring, and neuroendoscopic assistance gives you all these facilities. In familial cavernomas, I think it is accepted that these small punctate lesions need not be treated, but this is one patient who was operated already outside for this cavernous angioma and had this small cavernous angioma in the brainstem. And we decided to wait for it when he came for a second opinion. But this bled about 3 years later, and then almost a month later, he bled once again. Then we had to operate on it and remove this completely through the floor of the fourth ventricle. So familial cavernous angiomas, I think surgical intervention has to be considered following second hemorrhage. And I think there are now several studies which are trying to show that propranolol may have some protective influence, especially to be used in familial cases. And there is some genetic predisposition which has been shown in these polymorphism in genes, which probably relate to the oxidative stress and inflammation. There is also some mutation that has been found in cases which have shown excessive aggressiveness, but how to identify such patients still remains a problem. I think it is agreed that patients who have an associated venous angioma, it should probably not be interfered with. And does it increase the risk of intracranial hemorrhage? I think there is a equivocal evidence about it. Does physical activity allow the cavernous angioma to rupture? I think so far a population study in Britain has shown, and Canada has shown, that it does not really cause any increased risk. I think I have shown you a few interesting cases and some new information, and I hope this is useful. Thank you very much.
Okay, thank you, Dr. Dr. Deopujari. I think you give us quite a lot of answer about some very interesting question, especially for the brainstem cavernous angioma, and you showed a very nice video about your surgery. Let me see if there are any question from the audience.
There is one question about how do patients usually present. So the usual presentation is either with seizures or with increased neurological deficit due to seizures. Very few cases present with non-localizing headaches. These are the three most common, I would say. Any other questions in the chat?
So what about gamma knife?
So gamma knife, it's a very tricky question because earlier literature, especially, Kondis-Holka and the Pittsburgh group, when they first wrote up, they advocated using gamma knife for cavernous angiomas. But the data, if you read carefully, you find that it does not protect you from hemorrhage in the first 2 years. So patients who present with clustering of hemorrhage, they are not protected. The second funny thing was, unlike all other pathologies which we treat with gamma knife, in cavernous angioma, reduction in size of the lesion is never seen. Disappearance of the lesion is never seen. So unlike arteriovenous malformation, what should you call success is really an important consideration. So absence of hemorrhage, is it natural history or is it cavernous, is it radiosurgery working, is the main question. Therefore, I think usefulness is undetermined.
Okay, yeah, good. Okay.
You have any opinion, Dr. Zhao? You can tell us.
Actually, yeah, in China, there are some different opinions. For me, I don't use gamma knife for any cavernous malformation. But I know there's some other neurosurgeon, they maybe think gamma knife still have some effect for some like a deep located rebleeding case. But I'm not sure because there's, just as you mentioned, there's no evidence about if
There is no
gamma
end point. It becomes very difficult to say.
Yeah. Yes. So I don't know. For me, I don't recommend gamma knife for my patient with cavernous angioma. Yeah. Okay.
There is one other question in the question box.
Yeah.
How do you differentiate between cavernous angioma bleed against, say, other causes of bleed like hypertension or others? So I think there are two important things. One is the very fact that the cavernous angiomas occur usually at cortical, subcortical, borders in supratentorial region, or they occur in basal ganglia itself, while the bleeding of AVM can probably be considered as a differential diagnosis, but most other hemorrhages can be separated from it. And I think if you get a hemorrhage in the brainstem, cavernous angioma is more likely than AVM. I think you are a vascular surgeon. You would also vouch for that, I'm sure.
Okay. So there's another question about CT angiogram. So do you do the angiogram for your patient with the diagnosis?
I do angiogram only if the patient presenting for the first time and patient is bad enough to be operated. So if I'm operating on somebody for the first bleed, then I would do a cavernous, then I would do an angiogram. Patients who usually present for second or third bleed, the diagnosis is very easy to find. The salt and pepper or the repeated hemorrhages and the localized nature makes it very easily to identify.
Okay, Dr. Harshad, do you want to?
Harsha, that's some
say-
question.
Yeah, I think he had some comments, I think. I don't know if he's able to talk. And
Hello.
I'd like-
Hi, John.
Go ahead. Hey, Harshad, welcome.
Hi. Yeah, Dr. Shekhar, excellent presentation, I said, and wonderful techniques you have seen. I just had a query. What is the incidence of a rebleed in cases of cavernomas?
Incidence of?
Rebleeds.
Incidence of rebleed is supposed to be as high or higher than that is why I showed you that Lancet paper. It is
Yeah.
about 4% per year, but if the patient has had one bleed, then chances of rebleed go up to almost 8%. And if you have a lesion in the brainstem, it is almost about 18%. And in as I showed you in the Japanese paper, it is 42%.
Oh, very high. Many times, in our practice, we try to conserve them, especially brainstem hematoma or some other hematomas with underlying pathology, and they don't come back or they don't agree for a surgery. And that is why I thought, what is the incidence of a rebleed?
I think depending on the area of brainstem involved, depending on if you see hemorrhage of more than one, age. I mean, if you see that the patient has probably hemorrhage of two different ages, something old, something new, then I think you can be very sure it is cavernous angioma. If you have just a primary recent bleed, then you have to consider other possibilities.
Right.
And in a relatively young patient.
Yes. Okay. Thank you. Excellent presentation.
Hey, Takashi Khan, welcome. Do you have any comments? Takashi?
Yeah, thank you for the nice lecture. So, I sometimes encounter cavernous angiomas. I have one question. There are several cases of repeated hemorrhage. And in that case, so hemosiderin is also attached to the brain, and post-operative seizure is making a pain problem. So post-operatively, how do you manage the post-operative seizure?
I think if you are operating predominantly for a seizure syndrome, then I think you have to take out the hemosiderin ring as far as possible. Unless you are really working in an eloquent area, then you take all precautions like what we did with that doctor we did awake, and we tried to remove as completely as possible. Actually, we had to do a 2-stage surgery in that lady because first time she had some speech difficulty. So that is one thing. And I think in terms of management of seizures post-operatively, you have to use all the tricks which you do for, failed seizure surgery.
Okay, thank you.
Okay, are there any questions? If no question, okay, so thank you, Dr. Deopujari, for your wonderful lecture.
Thank you.
About cavernous angioma. Thank you again. So will you come to China for the ACNS meeting?
Well, I think my junior partner, my colleague is likely to come. He has a lecture there, but there seems to be some problem in visa right now. So traveling is not as easy as it was 3 years ago when we enjoyed Beijing.
Yeah. In China now, still, if you any foreigner want to travel to China, you still need to be quarantined for 10 days.
So I think that's the main reason. Probably he is giving an online lecture. Yeah.
Okay. Yeah. I think now the meeting is scheduled to be held on October. The last weekend of October, right?
Correct.
October 29 and the 30. So I'm not sure. In Shanghai, right? Yeah, I'm not sure.
Sorry, I won't be able to attend, but I'm looking forward to another opportunity.
Okay. Anyway, yeah. Welcome.
Yeah, excuse me, Wan Lee, I'd like to make an announcement for Dr. Deopujari. We're
Okay.
developing a channel, gammaknife.tv. I don't know.
Yes,
Ah,
yes.
wonderful.
You may be
Manjul
interested.
told me it would be nice to attend in near future. Yeah.
Well, you know, I'm not a neurosurgeon, but it seems that the general surgical population doesn't know a lot about gamma knife. It'd be nice to educate the community, the world community. Anyways, back to you, Wan Lee.
Wonderful. Okay. So now let's move to the next speaker, Professor Zhang Wei. He's he's a vice chairman of our neurosurgical department and also director of our Glaucoma Center of the Beijing Tiantan Hospital. So tonight he will talk about the MR radiomic approach to predict overall survival and tumor infiltrating microphage in gliomas. So please, Professor Zhang.
Thank you, Dr. Zhao. Hello, everyone. Hello, every professor on the website. I will share my screen first. So can you see my screen now?
Yes. Yeah.
Okay. I'm Dr. Zhang from Department of Neurosurgery, Beijing Tiantan Hospital in China, Beijing. Today is really my honor to have this opportunity to share my recent work here at this online meeting. My topic today is an MRI radiomics approach. This is a model to predict overall survival and tumor infiltrating macrophage in gliomas. So this is the content of my speech. Background, radiomics prediction model for overall survival gliomas, and summary. So background. Nowadays, modern medicine has fully entered the big data era. Doctors and researchers are faced with a large amount of data in clinical research every day, such as the medical records, image data, video data, electric, physiological data, and multi-dimensional omics data. So we can find multiple source of big data, omic data from the website. As we all know, NCBI, National Center for Biotechnology Information, DDBG, a Japanese DNA database, BIGD, Life and Health Big Data Center. We also can find some tumor-related database, as for example, TCGA, the Cancer Genome Atlas. We can also establish our glioma genome database in China, the Chinese Glioma Genome Database, CGGA, and the Asia Glioma Genome Database. So let's talk about the cancer genomics. The tumor or cancer genomics is an biological discipline that collectively characterized by studies of all tumor genes and compared different genomes. So the objective or aim of the study is to find the structure, function, evolution, location, and editing the genome and their impact on tumors. So we can use these tools and methods to bioinformatics, genetic analysis, gene expression measurement, and gene function identification. Radiomics, with the help of computer software, we can label the tumor and extract the tumor features from the medical image, and most valuable radiomics feature are screened and by machine learning and some method to analyze the clinical relationship. So the clinical application of radiomics, we can use this method to do the quantitative study of tumor tissue, genetic analysis of tumor, clinical grading and staging, tumor efficacy evaluation for therapeutic response and to guide the individualized clinical diagnosis and treatment. So GBM is the most common primary intracranial malignant tumors in adults with a very high modality, disability, and a high recurrence rate. So at present, the standard treatment strategies for GBM is surgery, radiation therapy, and chemo, and the newly confirmed Optum TT fields. But now, as the most common primary malignant tumors in human, for glioblastomas, the median survival time is only 14 months, and the 5-year survival rate is less than 10%. Therefore, this is urgent to develop deeper insight into tumor biology and find genomic variations in this tumor. So this is the pathological definition of glioma. This is definition from a review about 150 years ago from Carl Virchow, very famous pathologist. Traditionally, glioma, especially GBM, are characterized by histological features, including necrosis, microvascular proliferation, invasion, nuclear atypia, and mitotic activity. Gliomas are often enormous tumor of brain-like appearance with very slow clinical evolution, never showing a clear limitation towards the normal brain tissue, but resembling more hypertrophy of the involved part than real neoplasm. So the most important feature for GBM is heterogeneity, not only in cancer genetic, but also in tumor imaging. Here, I'm showing here 4 cases of GBM with the same molecular features. In clinical practice, we can see that the recurrent and the progression of glioma always comes with changed MRI features, which may reflect the histological grade to some extent. So this is the radiomics research is a promising field. As we all know, the following features show that the basic process of radiomics research. First, the MRI scan is completed. Tumor extent is tumor labeling. We do the tumor labeling first, find the features, extract the features from the MRI scan, and do statistical analysis by machine learning or mathematical method to do the relationship analysis or association analysis and so on. So this is a paper as early as 2008 in PNAS, when gene chip technology was just emerging. Were very exciting. We were very excited to see that researchers at that time found that the different imaging features of gliomas often corresponded to genomic variations such as contrast enhancement, mass effect, necrosis, and so on. So the final conclusion of the paper was that distinct subtype of glioma, such as invasive type or edema type, had significantly different tumor genetic changes. Another paper, a decade later, researchers using machine learning radiomics analysis to guide the molecular classification of glioma. In this research, a total of over 200 glioma patients were enrolled in a study, including 100 cases of glioblastoma and 108 cases of low-grade gliomas. The authors used used the MRI radiomics to construct a 3-layer machine learning model to subclassify gliomas. The accuracy of molecular typing, subtyping based on imaging phenotypes reached over 81%, and the accuracy of diagnosis reaches over 90% when combined with histopathological diagnosis. Radiomics and survival prediction. This is an interesting paper. A total of over 200 patients diagnosed with GBM were retrospectively analysis and assigned to the training and testing set. Imaging features were extracted for multi-parameters, MRI sequences, or MRI features. A random survival forest model was used and established. MRI image and phenotype combined with clinical and genetic characteristics can improve accuracy of survival prediction for glaucoma patients. This is another paper. At the same year, the Moscato study on Lancet Oncology analysis, the enhanced CT scan image and tumor biopsy RNA-seq data from over 100 patients with solid tumor. All the tumors and patients received PD-1 and PD-L1 immunotherapy. Machine learning methods were applied to construct a prediction model. As a result, the radiomics prediction model can be used to evaluate the number or the percentage of CD8 cells in patient and predict the response of PD-1, PD-L1 immunotherapy. So molecular genomic prediction in this field, in our recent work, my group constructed a stable and validatable preoperative T2 weighted MRI-based radiomics model for this patient to find the relationship and this model with patient survival. This is our database, CGGA database in China. This is the largest glaucoma genome database. This database is freely open to cancer researchers from all over the world at present. The established of CGGA database, we can use the database to find a large number of genomic variations for this tumor and find and do the comparative analysis from different populations to guide some drug discovery and target finding and so on. Taking advantage of this database, our team firstly reported that this newly characterized fusion genes in recurrent glaucomas and developed a MET target drug. This drug is we are doing phase 3 clinical trial in China. We will complete the trial this year. We can find that this drug is very useful in these fusion genes patient. This achievement was published in Cell Journal and was rated at China top 10 advances in life science in 2018. We also completed the largest long-term follow-up study in a single center in China from this database. Till now, the CGGA database has become the partner database of China National Genome Data Center. This is the genome features extraction from MRI image based on the image genomic data from CGGA database. MRI radiomics feature were extracted from T2 sequence, and all grade of gliomas after the tumor boundary was labeled by neurosurgeons and neuroradiologists. And there are 167 patients from the CGGA database in the discovery group, 261 patients from TCGA database in the independent validation group. And we also constructed 200 24 patients from CGG database in the prospective validation group. Finally, we successfully extracted over 1,000 radiomic features and selected 14 radiomic features associated, significantly associated with poor prognosis, and use this radiomic feature to construct a prediction model. This is the model. Statistical analysis shows that the radiomic features based risk score analysis, we can divide the patient into two groups: the patient with low risk and high risk patient. This risk score is an independent prognostic features for survival of patient with glaucoma, not only in CGGA database and also in TCGA independent validation cohort. This is a multivariate Cox regression analysis. This radiomic feature score is an independent prediction factor. To prospectively and independently validate our finding of this model, a total of over 400 patients with glaucoma in our single center were included. Patients with recurrent glaucoma, incomplete pre-operative MRI scan, or lost follow-up were excluded. And finally, 224 patients were included in this prospective validation group. Excitingly, the KM survival analysis and the Cox regression confirmed that this radiomics model accurately predicted the prognosis of patient in with glaucoma. In fact, the radiomics model has been validated and this part of work is over. But to our knowledge, in the field of machine learning research, the biggest challenge is to how to know the relationship between the mathematical models. So since the patient were all from CGG database with transcriptional sequencing data, so radiomics and RNA-seq genome data were integrated and analysis to annotate the MRI features from the gene function. As a result, interestingly, radiomic features were found to be associated with tumor macrophage infiltration in our study. We can see this is the top 25 immune cell signature correlated with this model. Then clinical samples were collected for experimental verification of the correlation between MRI features and immune function. The tumor was divided into two parts. One is for our single cell sequencing, and another for immune histochemistry staining. Notably, 3 macrophage markers, including MS4, A4A, step 1, collect 20, were all found to be significantly upregulated in high-risk patients. We also confirm our findings in our single-cell sequence data. We can see that the result confirms that the proportion of a macrophage was significantly increased in high-risk patients. We can see the macrophage percentage is over 50% in all the 2 high-risk patients. After a peer review of about 8 months, this research work were finally published on Brain Journal. The prediction model will also obtain a software patent in China. We can use this patent or use this software method to do this model for clinical using. So a brief summary, multiple omic data is increasing rapidly at present. How to analysis and utilize this data is the greatest challenge. So machine learning, as we used in our study, are widely considered as one of the main solutions in big data era. So based on CGGA database, the largest Chinese glaucoma database, we can perform integrated deep analysis from transcriptional, translational, and functional levels. We can find the relationship between clinical prognosis and the tumor biology. So the innovations and the limitations for our study. In this study, we constructed radiomics model to predict glaucoma patient survival by using machine learning method. We only extracted the radiomic features from MRI T2 sequences. We think that T2 sequence is not only the widely used standard for renal response assessment system, but also reflect the whole functional status of tumor cell and immune cell. Another innovation of the study, we used independent sample group for prospective validation and did functional annotation at a single cell level. The main limitation is that we think the effectiveness of using another MRI sequences to establish a different prediction model still require more effort to explore in the future. So this is a Tiantan glaucoma precision medical team. During the past 20 years, my supervisor, Professor Tao Jiang team, has formulated 10 Chinese and English clinical practice guidelines and expert consensus, which are leading the development of treatment practice for glaucoma in China. So Professor Jiang from Beijing Tiantan Hospital and Dr. Alfred Yang from MD Anderson are my supervisors. This is my research team. We are now working on developing innovative immunotherapy for glaucoma patients. That's all. Thank you. Thank you for your attention. Thank you.
Okay, thank you, Professor Zhang. I saw some question from the panel. The one is, can functional MRI and PET analyze the change of metabolism to form metabolic radiomics combined with the tumor-related gene change shown by radiomics? So yeah, functional MRI and PET.
Yeah, a very interesting question. I think the answer is yes. Functional MRI and PET is also widely used in tumor diagnosis and glaucoma diagnosis in our practice. So, but we have not do some analysis or based on functional MRI or PET imaging. Maybe we can try in the near future. Thank you.
Okay, thank you. And there is another question about microglia cell.
Yeah. As we all know, the glaucoma microenvironment is very complex because of the glaucoma is considered as the characterized by its heterogeneity. When we talking about the microenvironment in glaucoma, we can see different immune cell. Maybe we we do some single cell sequencing our samples to do the subclassification of the immunocell in this glioma microenvironment, and found that we can see the 14 radiomics model is very was associated with macrophage. We cannot find the relationship between this model with microglia. I don't know why, but I think microglia is another question for our deep research, I think.
Okay, thank you. So, are there any questions?
Yeah, thank you very much for this very nice work. Congratulations. I would like to just to know why you chose the T2 sequences rather than the flare.
Yes, a very good question. Because as we all know that T2 sequence is used as a renal assessment system for lower grade glioma to assess the therapeutic response and for tumor for the tumor. Maybe we do the tumor labeling in our practice and find that we can find the tumor boundary is the widest in T2 sequence. We are now doing another topic or research on other MR sequences. We cannot find the relationship. Maybe there are some underlying mechanism or some reasons.
Okay, thank you. Thank you very much.
Thank you.
Yeah, Saeed is from the island of Reunion in Africa, off the east coast of Africa, right, Saeed?
Yes, it's a French overseas department in the Reunion Island. It's near Mauritius.
Oh,
Thank you
very
very much.
far from.
Thank you.
I bet you couldn't find it on the map, John Lee.
Yeah.
Mohammed Helmi, welcome. Are you hooked up to the audio? Mohammed,
Hello, John.
welcome.
Welcome. Thank you for these informative lectures. I really enjoyed a lot. I have a question for the professor, the first speaker, Professor Chandra, I think.
Please
Hello?
go ahead.
Yeah, regarding the cavernous angioma in eloquent areas, especially mesial temporal lobe. Usually, we have a debate between who should do it, cerebrovascular surgeon or functional surgeon.
I think the decision is probably not so important in a country like ours, where many of us practice many specialties. But I think your question is that which patient should be treated as epilepsy surgery when you have a cavernous angioma in the temporal lobe. And I think
Exactly.
my answer to the question will be that if you are doing it for a mass lesion, or if you are doing it for just a single seizure and hemorrhage, I think I mean a general neurosurgeon or a vascular neurosurgeon is good enough. If you are doing it mainly for a chronic seizure disorder, like several seizures over 2 or 3 years, and you have a real dilemma as to should you remove just the medial temporal lobe or should you do a full temporal lobectomy, etc., then I think a epilepsy team has to come in.
Okay.
I mean, I have discussed this particular topic with Dr. Ratka, who's predominantly an epilepsy surgeon, and he says that their current practice is that they would do it as a stage surgery, remove the cavernous angioma irrespective of the status of epilepsy, and if it does not work, then to go for a comprehensive epilepsy workup and second surgery.
I see. Thank you so much.
Yeah, I think it's an interesting question. Even in our hospital, we have the same problem. For some vascular surgery, maybe we just remove the cavernous angioma. But if the similar patient with a seizure attack, the epilepsy surgeon, they maybe prefer to remove the whole temporal lobe. So I'm not sure what the exactly criteria.
Yeah, exactly, Zhao, because we here in Huashan Hospital, we have the same dilemma. Whether
yeah.
patient with mesial temporal lobe with epilepsy should go for vascular team or functional team.
I'm not sure. Yeah.
Okay, thank you.
Interesting.
Okay. Are there any other questions or comments? So yeah, John, do you have any?
No, it was a good session. A lot of interaction and questions.
Yeah.
Very good. I think you covered everything, Wan Lee. I think we got
Okay. I see.
any parting comments or anything from anybody? Or does anybody want to say hello to the community? If not, Wan Lee, I guess we'll wrap it up.
Yeah,
Okay.
that's okay. Yeah, I think we thank you again for two speakers, Professor Deopujari and Professor Zhang, and thank you everyone here. And we can meet again after 2 weeks.
Very good.
Right. Okay.
Very
Thank
good.
you.
Thank you, Wan Lee.
Thank you.
Thank you,
Thank
everyone
you.
else.
Bye.
Thank you.
Bye. Bye.
Bye-bye.
Bye. Bye.
See you. Bye.